In early 70s and 80s, when organ preservation procedures were performed across all sites in the body, multiple series came wherein limb salvage procedure was done along with adjuvant radiotherapy. And you can see that these publications in 1970s and 80s showed that local control rates were optimal. This paved way for the landmark randomized controlled trial in which half of the patients underwent amputation, the remaining half underwent limb salvage surgery with adjuvant radiotherapy. It was seen that the survival outcomes were same, but obviously local recurrence was much less in patients who had amputation. So essentially, radiation is given to improve local control. The indications of adjuvant radiotherapy are positive or close margins, high-grade tumors, large tumors, essentially more than 5 centimeters, or recurrent tumors. These are broader indications of adjuvant radiotherapy. This study was followed by two studies, one in 96 and 98. They were published in JCO, in which they wanted to find out whether limb salvage surgery can be done without using adjuvant radiotherapy. And both these studies, this study by Yang showed that when external radiotherapy was not given, local recurrences were significantly high, but there was no change in overall survival. This study by Pisters was published in 1996. In this, again, half of the patient underwent limb salvage surgery. The other half received brachytherapy. The first half did not receive brachytherapy. And it was seen that when brachytherapy was used, that is when adjuvant radiotherapy was considered, local control rates were significantly higher as compared to in patients where adjuvant brachytherapy was not given, and there was no difference in overall survival. So these two studies essentially made adjuvant radiotherapy a standard of care when a limb salvage surgery was done. Following which, there was this study which compared preoperative radiotherapy versus postoperative radiotherapy. The end point of this study was wound complication. And it was seen that there was not much difference in terms of local control or in terms of overall survival. But what was understood that when preoperative radiotherapy was given, the post-operative wound complications were higher. If you look at the aggregation of cancer databases, you will realize that radiotherapy plays a very important role. It actually doesn't matter in terms of outcome whether preoperative or post-operative radiotherapy is given. Both of them have their individual pros and cons. With post-operative radiotherapy, there's no delay in surgery. You have the full specimen with you. There are lesser wound complication. And another very important advantage is that when you give post-operative radiotherapy, brachytherapy can be considered. With preoperative radiotherapy, the volumes are lesser, the dose is less, and subsequently the long-term side effects are lesser in preoperative radiotherapy. So it is all about, balance. Most of these concerns are theoretical. We have to understand the local control is the same. What we are balancing is more acute wound complications in preoperative radiotherapy versus more long-term toxicities in post-operative radiotherapy. Again, if you look at the National Cancer Databases and the SEER database, you will realize that radiotherapy plays an important role, be it preoperative or postoperative. When we dig into the wound complication as well as the late radiation toxicity of these studies, we know that over time, both preoperative radiotherapy and postoperative radiotherapy kind of more or less balance out. The same authors of the preoperative radiotherapy study also came up with a scar-preserving radiotherapy model in which the wound complications could be reduced. When we talk about radiotherapy margins and doses, they all have been pretty standard since the time radiotherapy started playing a major role in the treatment protocol of soft tissue sarcomas. In general, the doses that we give for adjuvant radiotherapy is around 60 gray, and for pre-operative radiotherapy, we give around 50 gray. If you see on the right side, the upper photograph, we essentially immobilize the site that we want to give radiotherapy to. Uh, uh, the GTV essentially stands for the gross tumor volume, which is seen in imaging. CTV means the disease, the microscopic extent of the GTV, and PTV is the planning target volume, which we essentially give to manage the setup errors and the mobility. When we talk about conventional versus conformal radiotherapy, just to make it very simple, conformal radiotherapy means that the doses that we give conform to the target volume. And if you compare the right image with the left image, you will realize that the red and the orange part of the doses conform very much to the target volume as compared to the picture that you see in the opposite side. We talk a lot about IMRT, and with IMRT, we see that the doses to the bone, to the soft tissue, to skin are significantly reduced. And we understand that by reducing these doses, we also reduce the toxicity. And if you look at the literature that is available, which compares IMRT versus conventional radiotherapy, there are multiple such series. This one specifically from MSKCC showed that though this is not a randomized control trial, said that local control rates were probably better with IMRT, but we consider that if your target volume delineation is fine, if you take care while planning your radiotherapy, IMRT versus conventional radiotherapy would not have much difference in terms of local control. So what should be the time interval between surgery and adjuvant radiotherapy? We really don't know. Obviously, we want to consider it once the wound is healed, and we would not want to wait more than 4 months. If we offer adjuvant radiotherapy more than after 4 months of surgery, we would have missed the window of having that benefit with adjuvant radiotherapy. So quite a lot, sometimes when we have margin positivity, we often give extra doses, which we call boost radiotherapy, but there is not much of evidence to say that boost radiotherapy helps. In fact, the toxicity, because the doses are more, is much higher as compared to when boost is not given. But for whatever benefit, if it is feasible, if the patient is tolerating radiotherapy well, we do give boost radiotherapy when the surgical cut margins are positive. This is a question that we face time and again. Can post-op RT be omitted? Yes, we all understand that there is a subset of patients which do not require adjuvant radiotherapy. Yeah. These could be superficial tumors, low-grade tumors, tumors that are small in size, which have been excised with wide margin. But we should also consider that the randomized data that is available does not support treatment with surgery alone when limb salvage is done. Brachytherapy is a very important aspect of radiotherapy in soft tissue sarcomas. It is considered an adjuvant radiotherapy. It is considered the most conformal type of radiotherapy. It could be a post-operative placement of catheters or intraoperative placement of catheters, wherein we insert flexible catheters. Proximity to bone, proximity to neurovascular bundle make this procedure challenging, but these are not absolute contraindications for brachytherapy. Obviously, it requires expertise, and not many centers have this facility available. We have to understand that the major advantage with brachytherapy is shorter treatment time as compared to external RT. And if you see the image on the left-hand side, you will see, as I said, that it is the most conformal treatment. You will see that the adjacent normal tissue is receiving much less radiation dose as compared to external beam radiotherapy. We again come across this question whether post-op RT can lead to an improvement in overall survival. The randomized control trials haven't reported that, but we have multiple case series with larger numbers which suggest an improvement in overall survival with post-operative radiotherapy. My presentation would be incomplete if I do not speak about the sequelae of radiotherapy, local edema, fibrosis, and subcutaneous. Subcutaneous fibrosis is commonly seen, But you have to understand that grade 3 and grade 4 complications are less than 5%, and in fact, actually much less than 5%. Sometimes you see wound complications, especially when neoadjuvant radiotherapy is given. Radiation-induced fractures are seen in less than 2%. And another thing that we obviously talk about is radiation-induced second cancer. If you look at the cumulative incidence, it is around 1% per year. Thank you very much for being patient audience. I'll stop sharing my slide.
Yes, Nehal. Thank you. Thank you very much, Nehal. That was a nice overview, and thank you for sticking to time. So it is, we have an opportunity for questions. So since this is an educational session, I would request everyone to feel free to, come online and ask a question, or if you want, you can actually type in questions. Anand, do we have about a couple of minutes for questions? We can't hear you, Anand.
I said we just have a couple of questions, maybe 1 or 2 questions. So if there's no one else, just to stimulate discussion. Dr.
I have a question.
Yes, please.
Yeah.
Samir.
So this, hi, Dr. Nehal, thank you for the nice talk. Is this radiation-induced sarcoma, is it stochastic or non-stochastic? Does it depend on dose of radiation, or it might happen at any dose?
So it is, if I just give you one word answer, it is not that easy. Second malignant neoplasias that generally happen because of radiotherapy, there's a very complex relation. It is seen in lower doses also, but is also seen in higher doses. In fact, the data from the childhood cancer survival study actually said that when you give doses less than 48 gray, this was a paper by Kutesh, which was published in JCO, there were no incidents seen when doses were given less than 48 gray. So generally more than 60 gray, you will see second cancers, but I would not say that lower doses cannot cause second cancers. In fact, you will see malignancies happening at the junction. But again, I would like to emphasize that the incidence is 1% per year. In fact, lesser than that.
Samir, just to add to what Nehal has said, to answer to your question whether it is stochastic or non-stochastic, just to explain to the non-radiation oncologists here, stochastic is also known as probabilistic, and the non-stochastics are the deterministic. By that, we mean probabilistic means whatever dose you do, you could end up developing a second cancer because of that. And deterministic are the ones like, skin reaction, mucositis, fibrosis, where you go on increasing the dose and the chances of having that increases. So Nehal has in a way answered the question in terms of the dose. So although we say that the second cancers can happen at any dose, what we have seen, as Nehal mentioned about the study from Kutesh, is that only after a particular threshold dose, the incidence increases. So although it is a probabilistic event that can happen, second cancer, but the incidence in sarcomas has been seen to be more of non-stochastic, in the sense it is deterministic. You give more dose above 60 gray, the chances are more, as per the study that we have seen.
A slightly simpler question, Dr. Nehal, and I think we can wrap it up for this round for the questions. Again, just for the benefit of students. So you have all the 3 modalities. There's a patient which is suitable for both preoperative radiation, say a simple tumor in the extremity, not abutting onto the bone, not abutting onto the vessels, and so on and so forth. The patient is suitable for both EBRT, pre-op RT, post-op RT, as well as brachytherapy. So if given a choice, what would be your choice of delivering radiation? Is it pre-op, is it post-op, or is it intra-op? Intra-op, I mean brachytherapy. Could you just lead us through these, your choice and why, quickly?
This is not a simple question, it's a debate question. And
yes,
I would answer in a way which will make Dr. Laskar happy. I'll tell you, it's all about, your own comfort of delivering the kind of radiation. So if I feel that this patient will be eligible, is a candidate for brachytherapy, I think upfront surgery followed by brachytherapy would be the best. I think Dr. Laskar can help me with this.
Oh, agree completely, Nehal. You did mention the advantages of brachy. It is shorter. It has probably less complications. So if brachy is possible as a single modality, we would obviously try to do that. But in case brachy is not possible, then we would. So in our institution, our policy has been to try for brachy. And so that is the reason we do most of time post-op radiotherapy rather than pre-op radiotherapy. And the other thing is, like Nehal mentioned, if you're doing pre-op, the greatest downside of pre-op is wound complications, unless you are trying to do, the wound sparing IMRT radiation, which may not be possible all the time.
Again, one last question. It's very similar to what Dr. Gaurav Das has already asked in the chat box. If you anticipate that the microscopic margin is going to be positive, the positive surgical margin is expected in the preoperative period, what would be, and suppose you could not give further margins because it's abutting onto a major nerve or something like that. So what would be, as a radiation oncologist, what would you say in the MDT? Would you say that let's give preoperative radiation and have a planned positive margin, or have a post-op radiation and have a planned positive margin? In other words, what is the significance of the planned positive margin in the pre-op or the post-op? Does the prognosis differ? Thank you.
So if we know that the margin is going to be positive, I think we should not prefer preoperative radiotherapy. Preoperative radiotherapy is essentially for borderline resectable cases, wherein your chances of getting margin negative improves with preoperative radiotherapy. But if the margin, if we know beforehand that it is going to be positive, I think we should go for surgery first, so that we can offer higher doses of adjuvant radiotherapy. But obviously, we all understand that margin is a very important independent prognostic factor in terms of outcomes, and we should try our best not to have a planned positive.
I think so. This, what Dr. Lashkar said and what Dr. Nehal said, kind of answers 2 or 3 questions. Dr. Siddharth spoke about the wound sparing IMRT. So there was a question, is there any other way to avoid the graft breakdown? So that's one way. The other way is, if you anticipate that you're only going to put a graft, as Dr. Nehal said, you can give preoperative RT. If the post-op RT, you don't have to put a flap, you can just put in a graft. And Dr. Gaurav's question was, what would be your delivery approach for microscopic positive margin? Maybe you should not do post-op RT. When you know that the planned positive margin is going to come, surgical margin is going to come positive, maybe we can consider pre-op RT. I think, Pratik, I think we are out of time for this talk. I think we've slightly exceeded the 10 minutes. Maybe we can go to the, I think Dr. Kadresan is still yet to join us. I think he's joining us. I'll just text him, I'll call him after the talk. Maybe we can go to Sameer's talk on the role of chemotherapy and principles of chemotherapy, why we really are giving chemotherapy in STS, how, where, and device. On to you, Sameer. For the uninitiated, Sameer is really one of our rock stars, one of the shining stars in sarcoma oncology. He's a faculty at the All India Institute of Medical Sciences at Delhi. One of the brightest that is there, and we get to learn from him as to what is it that we need to know about chemotherapy in soft tissue sarcoma. On to you, Sameer.
Sir, thank you, Dr. Anand. Thank you, Lashkar sir. Thank you, Dr. Nehal. Can you see my slides?
Yes, you are visible.
Yes,
and
Sameer.
Yeah. So I'll just talk about soft tissue sarcoma adjuvant therapy. Because the time is short, so I just chose adjuvant therapy, when to give, and what is new in adjuvant therapy. So before starting for any soft tissue sarcoma talk, I think pathology is the most important thing that should be emphasized. We have more than 100 histologic subtypes, and since now the treatment, especially chemotherapy, is histology based, so we need to pinpoint the exact histology. They have different, almost sarcomas with different histology have different behavior. Just like myxoid liposarcoma has propensity to go to fat. So abdominal imaging should be done. And in fact, it has also propensity for paraspinal or spinal location. So that imaging should be done for staging. Angiosarcoma and leiomyosarcoma, liver imaging should be done, especially if it is retroperitoneal leiomyosarcoma. Angiosarcoma and alveolar soft part sarcoma have brain propensity. Epithelioid sarcoma, clear cell sarcoma, they go to lymph nodes. So in fact, since most of your surgeons, so at lots of places for clear cell sarcoma, sentinel node biopsy is done. And for epithelioid sarcoma, at few places, sentinel node biopsy is done. So why expert pathology is required? I mean, pathology should be done at a center where we are routinely doing pathology, and sarcoma pathologist sees a large volume of cases, because there is major discrepancy for almost 30 to 40% across the world. And why, if it is a molecular, it is a sarcoma in which some molecular test is positive, like it's some translocation is positive or amplification is positive, that must be done. Because there is an evidence that over and above expert pathologist, if we do translocation testing, we change the diagnosis in almost 10 to 13% of patients, even with expert pathology. So with next generation sequencing, again, 10% of patients are have change in diagnosis. So before treating with chemotherapy any sarcoma, diagnosis should be very clear, and if molecular is available, that must be done. So why do we have chemotherapy? Because to improve survival, to decrease distant metastasis. Few papers suggest that perhaps local recurrence might also be addressed, but that is very doubtful when radiation plays such a big role. So what is the evidence of chemotherapy? It starts from 1997, where meta-analysis were done. There were non-specific meta-analysis. At that time, doxorubicin only chemotherapy was there. Ifosfamide was not there. It was tried in almost all histologies, chemosensitive, non-chemosensitive, all grades, grade 1, grade 2, grade 3. So it was a time when we lumped everything together and there was no splitting. And at that time, there was some percent of OS benefit. And this trend kept on repeating. There were further updated meta-analysis, which again showed borderline OS benefit. Some had OS benefit, some didn't have overall survival benefit. By overall survival, I mean overall life. And by distant recurrence, I mean mostly lung metastasis. So they kept on coming. So with after few trials and after a decade of trials in soft tissue sarcoma, they thought that probably we should divide sarcomas into high risk. And high risk sarcoma should be defined by more than 5 centimeter, deep seated and high grade. Again, histology was nowhere at that time. And this was the one of the initial trial that showed chemotherapy benefit. And it showed keep absolute overall survival benefit. But again, small sample size, histology not proven. Again, more, all the histologies were taken. Prognostic, we don't know how many of them are actually true high risk. And mind you, chemotherapy is quite a toxic thing in soft tissue sarcoma. The combination which is approved and which is used world over for adjuvant setting causes neutropenia in almost 40% patients. It causes infection in 9%, and again, side effects like nausea, vomiting, mucositis, grade 3, grade 4 in almost 1% of patients with 20% thrombocytopenia. So is there a tool that we can choose chemotherapy regimen? So can it be any histology based, or what are characteristics where chemotherapy should be given? So first of all, patient factor, it should be appropriate patient, good performance status, fit patient, young patient, who is able to tolerate this toxic chemotherapy dose. Secondly, again, this organ functions must be all right. Now, gradually we saw that tumor size, tumor histology is also prognostic. Tumor grade, deep location is now a doubtful prognostic factor, and microscopic positive resection margin for local recurrence. So now we look at the histology, we decide if it is chemosensitive, and then we decide chemotherapy. So this is how, if it is alveolar soft part sarcoma or extraskeletal myxoid chondrosarcoma, will not give chemotherapy in adjuvant setting. If it is myxofibrosarcoma, clear cell sarcoma, endometrial stromal sarcoma, probably MPNST also, again, adjuvant chemotherapy might not be given, but again, this might be discussed with patient on case-to-case basis, but they are relatively chemo insensitive. In fact, this epithelioid sarcoma is also kind of relatively chemo insensitive, and now that newer drugs are also there for this. LMS, chemosensitive, moderately chemosensitive, angiosarcoma, moderately chemosensitive. So adjuvant chemotherapy should be considered. And in case it is synovial sarcoma, myxoid liposarcoma, desmoplastic small gland sarcoma, uterine LMS, then they are chemosensitive sarcomas. So we give chemotherapy for this green and this light blue. The last two for moderately chemosensitive and chemosensitive. For chemo insensitive, on few of the histologies of relatively chemo insensitive, we don't give chemotherapy. So histology guides us regarding the sensitivity of these sarcoma for chemotherapy. What else? What else is new about histology? Now there are nomograms available. So the initial nomograms are from MSKCC, but now there are further update to these nomograms, and now it is available as a mobile app called Sarculator. So again, it has come from study of 1,000 patients and has been validated in Europe, in US study, and various study in a retrospective manner. What they found that we have now histology as important prognostic factor. What does that mean? It means that if it is myxoid liposarcoma 10 centimeter high grade, which is usually myxoid is high grade, and versus angiosarcoma, which is high grade, more than 10 centimeter, the prognosis of them might not be same. So saying that we will give chemotherapy in more than 5 centimeter high grade, any histology, any chemosensitive histology, even that is not right. So now we can actually calculate the kind of recurrence that or percentage of people who might recur with these sarcomas. As you can see, angiosarcoma has highest risk of recurrence. Myxoid liposarcoma is mostly low risk or intermediate risk. And as you can see, synovial is somewhere between. So there are lots of histologies that are not mentioned because the data for those histology is not known. But for these most common histologies, now we can tell what is the chances that a person has long-term 10-year overall survival. And would chemotherapy be beneficial or not? That we will see in future slides. So these nomograms, which are Sarculator, again, I think Sarculator is an app that every sarcoma oncologist should have now. Age, size, grade, and histology. Limitation is that not all histologies are there, as I said. So once those all failed trials, which had doubtful or ambiguous benefit of chemotherapy, once Sarculator was extrapolated, then it was seen that those with high risk, that is 10-year predictive overall survival of less than 60% by Sarculator, had risk of recurrence to decrease to almost 50% in the high risk histologies or in the patients who filled high risk as per Sarculator. And this was applied to at least 3 or 4 trials, and almost everywhere this took consistent result. So probably a chemosensitive histology, Sarculator showing 10-year probability of overall survival less than 60% is a conclusive indication for chemotherapy. Now, if it is, between 60 to 70 or 60 to 80% is a doubtful zone. If it is 70 to 100 or 80 to 100, probably no one will give chemotherapy in those cases. So again, this is we need to select a subset with sensitive histology with very high risk of recurrence. What about neoadjuvant chemotherapy? So whatever data is available so far comes from resectable sarcomas who have been given neoadjuvant chemotherapy. Italian sarcoma group and Spanish sarcoma group are the ones who have pioneered neoadjuvant chemotherapy and has been given in phase 2 and phase 3 trials. So this is one of the trial which compared, what Italian sarcoma group saw that after 3 or 4 cycles, the toxicities become overwhelmingly difficult to manage. So they said, they compared 5 cycles of chemotherapy versus 3 cycles of chemotherapy. What they saw, again, the inclusion criteria was routine. It was not based upon Sarculator. They were both high risk and low risk sarcoma, but they found that 3 cycles were almost non-inferior to 5 cycles. It was non-inferiority study, so not a superiority study, not an equivalent study, but 3 cycles in the patient who cannot tolerate chemotherapy beyond 3 cycles or having life-threatening toxicity or serious toxicity, probably 3 cycles are also adequate based upon this trial. So there was one good point about Italian studies are that they give neoadjuvant chemotherapy along with concurrent radiotherapy. So again, conventional wisdom says that chemotherapy and radiotherapy should not be combined because there might be local toxicities and doxorubicin potentiates chemotherapy. But this is the data here with Italian sarcoma group. And what they found that wound complication in patients who received preoperative chemoradiotherapy was only 7% higher than patients who received only radiotherapy, and dose intensity with chemoradiotherapy was maintained. So again, which is the best chemotherapy? This question has haunted us for a long time. And this is Italian Sarcoma group, where they divided different histology of sarcoma. Again, it is histology tailored, as you can see, and they tried different histologies, different chemotherapy. What they found that it was again 3 cycle of histology tailored chemotherapy versus 3 cycle of ifosfamide and anthracycline. And they found that ifos doxorubicin remains still the best chemotherapy because survival was almost inferior in all the histology tailored arm except trabectedin. So if some patient is not cannot receive doxorubicin, then trabectedin is the only drug that can be used in myxoid liposarcoma, but other therapies are largely inferior to ifosfamide doxorubicin. So this is further used in myxoid liposarcoma in neoadjuvant setting with very good results. So what I will emphasize is a very good pathology with whatever molecular marker that is available, because pathology is the most important thing in sarcoma. It is the foundation of treatment. Now we have circulator nomograms which can tell us exact chances of recurrence. And also we must give chemotherapy only in chemosensitive or relatively chemosensitive histologies. There is no point giving chemotherapy in alveolar soft part sarcoma or extraskeletal myxoid chondrosarcoma. Now, prognosis is histology based, so we must see the prognosis. So just like myxoid liposarcoma, they are mostly intermediate or low risk. They don't need chemotherapy. Ifos doxorubicin is the still best regimen, though it's a bit toxic. In myxoid liposarcoma, maybe we can use trabectedin. Preoperative chemoradiotherapy, there are many other trials, but can be used. And so far, the trials have happened only in resectable subset. For unresectable subset, we are giving, but the definitive evidence that it downstages to this much for leading to surgery is not there. Thank you. If you have questions, please feel free to ask.
Thank you, Samir. Thank you for the nice overview. Maybe we can have a couple of questions quickly for Dr. Samir.
So if there are no questions in the chat, I think there's one question by Dr. Gaurav. Samir, in the context of resectable sarcomas, would neoadjuvant chemotherapy help in R0 resection rate? If it does not, Dr. Gaurav, Dr. Samir, can you Dr. Gaurav's question?
Yeah. So I've read this. So in resectable STS, neoadjuvant chemotherapy, I mean, it was in context of trial. We don't give as of now. And the trials did not show very good response rates. I mean, Italians give it regularly, but the response rate, the RECIST response rates are very less. I mean, RECIST is 30% reduction. So in majority of the trials in which neoadjuvant chemotherapy has been given, as per Coe's response or as per MRI, less than 30% reduction was there. But otherwise, sarcomas are not such that they probably might aid in decrease in R0 resection. I mean, they're not this kind of sensitive. Most sensitive sarcoma is UPS. I mean, those Italian trials, UPS has good response rates. Synovial has good response rates. But for randomly sarcoma, neoadjuvant chemotherapy, if it is resectable, perhaps we'll go for surgery or neoadjuvant radiation in case.
And what is the risk of progression on NACT? If you could just give a number and then we could go to the next question.
So again, it depends on histology. So in India, synovial sarcoma is the most common histology. So in our cases, it should not be there. But in their leiomyosarcoma is the most common histology. And they have 30 to 40% chances that it might increase. I mean, response rate are somewhere 30%, 26%. And stable disease 30 to 40%, and rest of them progress. But again, in their trials, they find that none of them, the plan was not changed for any of them. The progression was not that blatant.
Okay, Samir, last question from me. So the Circulator app, do you use it for every patient in routine clinical practice?
Yes, I mean, it's a simple app. You just
put
histology, and then you get probability of overall survival less than 60%. So it's a simple, but in those who have predicted overall survival less than 60%, it's an easy task. But those with having 65%, 70%, again, it's borderline. For them, you will have to talk to them. See, this is your risk of recurrence. We give chemotherapy only if the risk of recurrence is 40-50%. I think we should give evidence this is not there. So that is case to case.
Okay. Samir, a quick question to you before we move on to the next. We probably didn't touch on it, but it is a very important, commonly faced question in our clinics. What about chemotherapy for patients with pulmonary metastasis? Should we give or not?
Sir, for which, I mean, for soft tissue sarcomas?
Yes, non-round cell soft tissue sarcomas, NRSTS. So what would you recommend? We face this problem. Patient comes to you with metastasis, lung, metastatectomy done. What do we do? Do we add chemo or not?
Okay, metastatectomy done.
Yeah, I'm just giving you a situation where metastatectomy done. Pulmonary metastasis, no local disease, bilateral pulmonary metastasis, there were 3 removed. Now what? Is there evidence to show that addition of chemotherapy helps?
Sir, evidence is not there. But again, how we practice or how people do is like, I've seen people practicing who are doing good work, that if it is chemosensitive and patient is chemotherapy naive, like synovial sarcoma, probably they will add towards chemotherapy. Again, in UK, they don't give usually, but in US, so they give. But if it is MPNST or it is alveolar soft part sarcoma, or it is non-chemosensitive, then they don't give chemotherapy. They just operate and keep under follow-up, sir.
Thank you. Thank you.
Thank
so
you,
if
sir.
There's none, over to Anand. Anand, you want to take over?
Yeah. So I think we have the next speaker, Dr. Kadresan, online. So over to Dr. Kadresan, sir, for the talk on principles of surgery in soft tissue sarcomas.
Am I audible?
Yes, sir. Yes, sir. You're audible, sir, and we can hear you very well.
Just a minute. I'll just try to. I think.
Dr. Samir, can you stop?
Samir has to stop sharing.
Yeah. I'm just doing it.
Sorry, guys, for the. Can you hear me, Anand?
Yes, sir. We can hear you very well, sir.
Okay. Sorry for joining so late. I got stuck in the traffic. I'm sorry. Basically, I've prepared this talk for the orthopedicians and newcomers for the
sir, you're not audible.
Just a minute, Anand. Hello, can you hear me?
Yes,
hello?
You are. Yes, slides are visible.
Yes.
See, I'll be talking on the principles of surgery in soft tissue sarcoma. So when we look at the principles, first we have to discuss about these 3 things, like biopsy, see what type of imaging we have to do, whether it is a CT or an MRI, and the role of surgery, especially in soft tissue sarcomas, and what type of margins and all those. Okay, so when we talk about biopsy, any soft tissue swelling which is more than 5 centimeters in size, we have to take it as soft tissue sarcoma unless proved otherwise. So a needle biopsy at least is mandatory to achieve at the diagnosis. Hello? Can you hear me, Anand?
Yes, we can. Go ahead.
Yeah. So at least a needle biopsy is mandatory to achieve at the diagnosis. If not, very rarely nowadays we do an open biopsy for soft tissue sarcomas. And mainly what we'll be looking at whether it is a sarcoma or not, and if at all possible, and whether it is a high grade or a low grade, where we'll be looking at adding brachytherapy or not during the surgery or immediately post-surgery. So that is what we'll be looking at. And excision biopsies we have to confine them only to lesions which are less than 3 centimeters or smaller superficial tumors, where we can do an excision biopsy if the suspicion is high, we can do a wider margin, excision with margins, so that we'll not be creating more morbidity for the patient, even if it is going to be a benign tumor. So then coming to the principles, we have to understand the natural history of the disease. We have to look at the stage at which we are diagnosing, the location of the lesion, and we have to be looking at the margins of resection, what we'll be able to achieve, and whether we'll be able to achieve a negative margin or not. and presence of metastasis. So when we look at the natural history of the disease, what we'll be looking at is the tumor per se is what will be there at the center of the thing. And there'll be a capsule kind of a thing, a pseudo capsule around the lesion, which will be actually a combination of the tumor cells and also the surrounding tissue, the reaction of the surrounding tissue to the tumor. So it will be having some amount of malignant cells within it. So we need to understand that this pseudo capsule, they are removing it with the pseudo capsule alone may not be sufficient in most high-grade sarcomas. And there can be skip lesions within the compartment where the tumor is arising. And there can be distant metastasis. So our evaluation should involve understanding the extent of the disease, that is the tumor, the pseudocapsule, or any extension along the tail, what we nowadays call as the tail of the tumor, which can be along the facial planes, which can be there, which also need to be understood before when we do an imaging for the sarcomas. And we should also be looking at skip metastasis within the compartment and also distant metastasis. So when we compare between whether a CT is required or an MRI is required, majority of the times now in today's practice, we do MRI as the preferred modality of imaging, especially in soft tissue sarcomas. We do also do CT scans and contrast enhanced CT scans, especially when there is vascular involvement or any other bony involvement, where our delineation of the bone and the vascular vessels will be much better with CT scans. So otherwise, MRI is much preferred, where it has superior contrast resolution, multiplanar capabilities, where we'll be able to appreciate and understand the proximity to the adjacent structures, and also sometimes vascular reconstructions are also possible with MRs. This is a patient. I just show an example between CT and an MR in a patient with a soft tissue sarcoma. This patient had a bony involvement, and where you can look at there is only a minimal thing which is seen on the X-ray, but on MR you could see that actually the tumor is extending well into the bone. And this is the bone scan which is showing some uptake. And when you see the CT, it is very easy to miss this component which is there, which is going into the bone. While in MR, because of the superior contrast differentiation, you could appreciate the involvement of the bone and also cortical involvement much better in this patient. You could see the CT and the MRI, comparative images of the CT and MRI, where the delineation of the tumor between the muscles and the surrounding tissue is much better. And also within the bone also, because we have multiple sequences, we'll be able to differentiate the involvement of the bone also in MR better than in CT. This is again another synovial sarcoma of the pelvis, where you could see the bony involvement and also the spinal extension into the spinal canal much better on MR. So as I've already told, CT also has a role, especially in patients who are claustrophobic with metallic implants and in patients with vascular involvement. The bottom line is the surgeon should be familiar with whatever investigation, and it is preferable to discuss with the radiologist if we do an MR, and then to know the exact extent of the disease before we plan the resection. And as we all know that the metastatic workup should include an X-ray and a CT chest to look for distant metastasis. And in some cases, we need to do CT abdomen also to look at any liver metastasis. So as we all understand that this management of soft tissue sarcoma is multidisciplinary. And as we had in the previous talks, we need to understand few other things, especially whether it is a pediatric or an adult, whether it's a round cell sarcoma or a spindle cell sarcoma, because the effect of chemotherapy varies. And so in round cell tumors, maybe we'll be looking at giving neoadjuvant chemotherapy followed by surgery, and whether it is in the extremity, head and neck, or in other sites. And as I've told, that surgery is the mainstay of treatment. The aim of the surgery will be complete removal of the tumor en bloc with adequate margins. So when we talk as adequate margins, what is an adequate margin? An adequate margin which should include the tumor, the pseudocapsule, the reactive zone around the pseudocapsule, and also a rim of or adequate amount of surrounding normal tissues around the reactive zone, which should also include the scars of previous surgeries. So these are the types of resections which were described. One is intralesional, is just removing the tumor within the pseudocapsule. Marginal excision is around the pseudocapsule. A wide excision is with adequate margins all around the pseudocapsule. And compartmental excision is another thing where the entire compartment is resected so that even the skip metastasis can be taken care. So an ideal margin is a 2 centimeter margin of normal tissue all around the lesion is sufficient to call it as a wide margin. In some areas like bone, neurovascular bundles, or critical tendons or so, you will not be able to achieve 2 centimeter margins. In such settings, especially in these facial barriers, we should be, sorry. So in these areas, the facial barriers, the fascia covering the vessels, fascia covering the intramuscular septum, or the perineurium or periosteum also can be uninvolved. Periosteum, perineurium can also be taken as an adequate margin if they are 1 millimeter thick and if they are not involved by the tumor. So when we plan surgery, we need to assess the extent of the tumor with clinical examination and imaging. We need to rule out metastasis. We need to prepare the parts and patient regarding the extent of surgery, possible complications, need for any other organ resection or nerve resection or vascular resections and bony resection. And then we need to keep the reconstruction options as required. And along with that, we need to have the other specialists like plastic surgeons. Majority of the times we need a flap to cover the defect, and a vascular surgeon or an orthopedic surgeon to help us in resecting the adjacent structures when it is required. So we need to have an adequate, an optimal incision, which should be able to give us a wide view of the entire thing, and then to resect it with adequate margins. We can do frozen section of the margins if required, and if there are any close margins, if it is there, or over the nerves or somewhere where we are just taking the perineurium, we can do frozen section to look at the adequacy of the margins. And then we need to ideally place clips for the to mark the field of resection so that it will be useful in planning radiotherapy. And then whatever it is resected, then it needs adequate reconstruction when other adjacent structures or when a large amount of skin is required, so that the subsequent treatments like radiotherapy and chemotherapy will not have any issues. We will not have any issues with those treatments. So we need to try to place the drain as close to the scar of the as possible, so that also will be included in the radiation field. So as I already said, the aim of the surgery is to achieve a concept of wide margins, to achieve it, which is aimed at achieving microscopic negative margins. And we should understand that radiotherapy cannot compensate for an positive margin. We'll usually give radiotherapy, but our aim should be, what I want to mean is that our aim should be to achieve at a negative margin, and we should not keep radiotherapy just for getting a positive margin. And as I've already said, the radiotherapy can take care of adjuvant, skip lesions, which are there away from the tumor within the same compartment. And it will be a useful adjunct to surgery. This is a patient with a soft tissue sarcoma, which is infiltrating onto the bone, which was resected and then reconstructed with the fibula, vascularized fibula. This is again another patient with a soft tissue sarcoma in the anterior thigh, which is involving the femoral vessels, and which is resected and then reconstructed. And the vascular reconstruction is done. So this is another patient with a soft tissue sarcoma, which is just abutting or adherent to the periosteum of the ulna, which was resected along with a portion of the ulna and then reconstructed with a pedicle flap. So the take-home message will be any soft tissue swelling which is more than 5 centimeters should be considered as sarcoma unless proved otherwise, and we need to do a biopsy before we plan the resection. And surgery is the main stay of treatment. Always aim to achieve wider margins, and appropriate adjuvant treatment will help to reduce the risk of recurrences. Thank you.
Thank you, Dr. Katharesh. So, one quick question to you before others can pitch in. You did mention about the importance of margins.
Yes.
Can you highlight and enlighten us a little bit on the concept of the planned positive margin, and where is it applied, and how is it different from unplanned positive margin? So that is a concept that all of us would want to know. Some of us would want to know.
Yes,
thank you.
That's a very good thing. Like I didn't touch upon all these because I thought it is for a basic the group of people. So a planned positive margin is also considered as a it's in some occasions, especially when it is very close to the vascular structures or very critical structures, when it is there, which is very close. In such a situation, we'll try to achieve wider margins in all other areas and try to be as close to the critical structure as possible, where we'll be planning to, as per our plan, we'll have a positive margin in that region, and we'll also place clips in that region so that we'll give radiation to that area so that the chances of recurrences are lesser, though we'll not be compromising in rest of the areas. So this is called planned positive margin. There is a study from the French group where they have seen that patients who had unplanned positive margin versus planned positive margins, the recurrences rates are much lesser or almost equivalent to wide resections when you take planned positive margins as compared to patients who had unplanned positive margins. So that is the thing we have to keep in mind, especially when we are closer to critical structures.
Thank you. Anand, any questions on the chat box that you would want to ask?
Dr. Katharesh, sir, there is 2 questions by Dr. Balamurugan. So one is microscopic margin negative? Is a microscopic negative margin adequate irrespective of histology?
See, actually, our aim should be to achieve 1 centimeter of margin all around, or at least a uninvolved facial barrier all around the lesion. But when we come to, when we look at the pathology, sometimes we get, just 1 cell margin or just less than a millimeter margin or something like that. So whenever we see such a thing, it may be, when it is feasible, it is preferable to go in and re-resect them, or unless it is very close to the critical structure. When it is when we have at least more than 2 millimeter or 5 millimeter margin, even after we plan a wider resection, then still we can accept that and then we can give radiation. But in this, very close margin is one we should try to avoid as much possible.
One last question is that many centers don't have frozen section to check on margin status. Again, question by Dr. Balamurugan. So when frozen section is not available, assessment of margin is done more of a blind approach by palpation. Is there any other better method than palpation if frozen section is not available?
See, the ideal way of resecting is that we need to have a pathologist in the theater, and then the grossing has to be done immediately so that we'll know exactly how much of margin in which part of the tumor we have given, so that we can look at getting the wider possible margin, especially in large sarcomas. But sometimes when we don't have frozen section, we have to try to achieve a wider margin so that our final histopathology will not have a close margin. That's what we should aim at. It is not mandatory to do frozen section in all cases, and many of the times we also don't do frozen in all the patients. But especially when we are closer to critical success only, we look at frozen section to look at the margins.
I think we are completely out of time in this section. So I think we will go on to the next. We will go on to the next section, which is I think which is when Kadresan sir can stop sharing. Okay, he's done.
Yeah, I will stop.
Yeah, so we'll go on to the next section, which is the case-based discussion. And since we are a little short of time, I would request Lashkar sir to please keep me on track. It's 6:30 now. We will stop at 7:02. We will stop half an hour. It was supposed to be a 45-minute session, but because we are late, we will stop at 7 o'clock. Please indicate to me at the 7 o'clock mark, and I will. I will stop.
Thank you.
Again, we have a big star-studded panel of people who are here as panelists. I welcome all the panelists here. We have Dr. Kadresan sir again. Here is there Dr. Jyoti Sharma, who is a faculty at the All India Institute of Medical Sciences, Delhi. Dr. Gaurav, again a faculty at the B. Barua Cancer Institute at Guwahati. We have Dr. Lashkar sir. We have Dr. Jifmi, again a faculty at the Tata Memorial Hospital in Bombay. And Dr. Sameer Rastogi, again, who delivered such a wonderful talk on chemotherapy from the All India Institute of Medical Sciences, AIMS. So again, quickly, is my slide visible, and can all of you hear? Great. Is it on full? Is it on full screen?
No, Anand.
No.
Okay. Is it now on full screen?
Yes, it is.
Yes. So before we start off this session, I'll be a little greedy, and I'll invite all of you to come to the Indian Musculoskeletal Oncology Conference 2023, March 3rd to March 5th at the at Hotel Hilton in Chennai. All the faculty that you are seeing here, which are part of this meeting, all of them are part of the main meeting as well. In addition, we have, a star-studded faculty across the country, across the world, some of the biggest names in sarcoma, and we have like a packed and a wonderful program hoping to excite all of you. And we have great prizes for postgraduates, both in terms of the free papers, in terms of the quizzes. And the quiz is something, it's a quiz with a twist, something to look forward for. So coming to our case-based panel discussion on soft tissue sarcomas, we have a 31-year-old gentleman with who was evaluated for pain in the left knee of 6 months duration. The clinical examination was a 7 into 7 centimeter mass with restricted mobility in the left distal thigh, anterolateral aspect. There was restricted range of movement, no significant inguinal node. Jyoti Sharma, what next? Dr. Jyoti?
Am I audible? Yeah.
Yes.
Good evening.
Yes.
Yeah, good evening, everyone. Yeah, so in this patient, this 31-year-old gentleman with a soft tissue mass. And so I would go for an imaging first in this patient.
What imaging?
So imaging, because it's a thigh, and we have already discussed in the last topics that I would ask for an MRI thigh in this patient first. So
when you ask for an MRI thigh and the tumor is very close to the knee joint, would you write something in the request again for the benefit of postgraduates?
Yes.
Ask for a contrast MRI, non-contrast.
Yes. Of course, it would be in contrast enhanced MRI. Yes.
Okay.
Because it's a restricted mobility, I want to see the local extent as well as involvement of the joint and the wounds.
So this is the MR that we have. Again, not going too much into the MR. So this is, we'll keep it pretty basic. So this is the MR that we have. So Dr. Gaurav, I'm going back and forth for these two images. What is it that you see? What do you see on the X-ray and what do you see on the MRI? I'm going up and down. You can tell me to go up or down.
Yes, sir. Good evening, sir. First of all, the MRI is not adequate. We need to include the entire limb.
Yes, the entire limb is included.
Metastasis.
The entire limb is included. I've just put representative images. There's nothing in the upper limb.
Yes, sir. Okay, sir. So this is there's a soft tissue lesion which can be seen in the lateral compartment of the thigh, and it is abutting the bone, that is the femur bone, and cortex doesn't seem to be intact. Okay. It's an intramuscular tumor.
So, and looking at this, would you say something else? Is it intra-articular? Is it going into the joint? It seems to get into the space between the patella and the femur.
Yes, sir. Difficult to comment if it is going into the joint space, but probably it is very close to the joint space.
Yes, and on the X-ray also, if you could go back and you could see that there is a hint of calcification when you go to there's a speck of calcification a small speck of calcification in the X-ray around the tumor that is there, probably somewhere there. But then again, so Dr. Gaurav, this is the patient that you have, the MRI is done. Dr. Jyoti asked for the MRI, you've seen the MRI, what next?
We do what is called a planned biopsy. For that, the clinical examination is one important factor. The second is the imaging. The surgeon who is going to do the biopsy has to review the imaging properly so that he decides where to put his core needle. And that core needle biopsy has to be done preferably by the surgeon himself in the institute where the surgery is going to be done. And he has to plan the biopsy in such a way that it is along the line of his future planned incision to remove the tumor. And it has to go through the shortest track, not violate compartments, preferably go through go without much dissection. Core biopsy anyway, we are not doing dissection. If we are doing an open biopsy, previously we used to do that. Nowadays with good core biopsies, we don't need to do that. If we do dissection at the end of the procedure, adequate hemostasis and representative cores, preferably multiple cores.
Right. Would you do, again, just for in the interest of completion, would you like to do a frozen section for adequacy of material? Do you do it in this case, or when is it that you would do it?
Frozen section is not frequently done, sir. We actually, when we take the cores, we inspect the cores. If we see the material, whitish color material, which is different from fat and muscle, that means that what we have taken is probably tumor that actually sinks in the neutral buffered formalin. So, which usually gives an idea that the material taken is adequate. If we have doubt, suppose there is a lipomatous tumor, we are not very sure that it could be having tumor cells or not, then we can resort to having frozen section.
Or maybe even when the tumor is largely necrotic, where there's a large necrotic component and then you're taking bits out, maybe you should not land up with, with necrotic bits. Okay, anyway, so the biopsy was done, which was a poorly differentiated sarcoma. Kadresan sir, is this biopsy enough for you, or would you ask for an IHC? Would you ask, now this is an easily resectable tumor, would you ask for a biopsy the IHC pre-op, or would you wait for the resection and then ask for the IHC in the post-operative period? So IHC when and where, now and after surgery, or only now? I mean,
see, the patient is a 37-year-old and poorly differentiated sarcoma. What I would be more looking at, I would like to discuss with the pathologist, is it a spindle cell sarcoma or a round cell sarcoma, because it is poorly differentiated. If it is a spindle cell sarcoma, I'll not be always looking at IHC right now. I'll be looking at resection as my main modality of treatment.
So, Dr. Kadresan, again, the metastatic workup, I've already put it up, the CT chest and the inguinal node FNAC. So, we had discussed with the pathologist, they said it was an undifferentiated pleomorphic spindle cell sarcoma. So, would you want to do an inguinal node FNAC in all cases, or would you do it selectively, or what is your policy on the metastatic workup?
See, if there is a palpable inguinal node, or if it is an enlarged inguinal node on imaging at least, then we'll do a biopsy. We'll do an FNAC. Otherwise, it is not routinely we do a FNA or a biopsy.
Right. So again, there are a few questions here that I think need to be answered. How, Dr. Kadresan, again, what would be, how would you identify involvement of the bone or invasion or involvement of the periosteum or bone by a soft tissue sarcoma? I mean, what would you think about it?
See, in this case, when we look at the MRI, there is a clear, at least a thin rim of normal tissues there between the tumor and the, and the lesion. If it is closely abutting the bone, see, the area of contact is what we have to be looking at. Then, if there is any suspicion, maybe we adding a CT or an CT will also help in identifying the bony involvement, especially when when it is very close to the bone.
Right. Dr. Jyoti, are there any predictors of lymph node metastasis in extremity soft tissue sarcoma?
Sorry, I'm not able to hear you.
No. I said, are there any predictors of lymph node metastasis in extremity soft tissue sarcomas?
I can't hear. Can you repeat the question? I'm really sorry.
No, I said, are there any predictors of lymph node metastasis in extremity soft
Okay.
tissue sarcomas?
Yes, so we have like few histologies which are known to have lymph node predilection for like metastasis, like rhabdomyosarcoma, synovial angiosarcomas, and clear cell sarcoma, and epithelial sarcoma. So these are the histologies where the lymph nodes are known to like metastasis is known, and in these patients we would like to evaluate the regional nodal basin, but not all routine sarcomas, because the lymph node metastasis is said almost around 5 to 6% in sarcomas. It is not more than that. So in only these particular histologies, we would like to evaluate for the lymph node metastasis.
Right. And now that this,
So,
yeah, please go ahead. Go ahead, Doctor.
yes, no. I was just answering another question, the sentinel node biopsy.
Yes,
so,
please.
Yeah, so routinely, I mean, in routine, we are not doing sentinel node biopsies in sarcomas, and I don't think there is any proven role for sentinel node biopsy in sarcoma yet.
Exactly. Perfectly said. It's only experimental. There's no role of sentinel lymph node biopsy in soft tissue sarcomas, even in the chemo sensitive histologies. So, Dr. Jifmi, now this patient comes to you. It's a pleomorphic, undifferentiated pleomorphic sarcoma, probably high grade, deep seated. It's close to the bone, abutting onto the bone. This patient would probably need, post-op RT. So, would you consider this patient, and it's abutting on the bone for a little bit of a distance? So, considering everything that Dr. Nehal had said, what would be your plan for radiation? Would you consider for pre-op RT, intraoperative radiotherapy, brachytherapy, or post-operative radiation? The patients come to MDT. I mean, what's your take on this?
Considering the site of the disease, it would be difficult to consider this patient for intraoperative placement of brachytherapy catheters, considering it's close to the joint and there could be a opening of the joint space. So I would tilt towards giving EBRT. Now, what setting this could be, it has been already discussed prior. So if this patient is considered for a wide resection, obviously wide resection, and a considerable part of the skin is going to be lost and a skin graft will have to be planned.
No, it's a deep-seated tumor. Maybe it's just going to come for, it's an intramuscular tumor.
There's some skin duration around,
so maybe it'll come for primary closure. So I know the benefit of the imaging, which you don't have. So I'm telling you that the lesion is amenable for primary closure.
Then probably, it could, both are good options, preoperative as well as postoperative. If in our institute, we would push for postoperative itself.
Right. I think we've made a little bit of a difference in that we've switched to preoperative radiation.
So I would just, in this regard, I would just tell you that globally, people have moved more towards preoperative RT. That is mainly considering the easiness in tumor delineation and more of acute complications, which can be reduced using modern techniques such as IMRT, and they are considered to be reversible, and they have shown to have lesser late complications, which are negated over the years. But yeah, because of these few reasons, globally, the whole radiation oncology population has moved towards giving preoperative RT. So there's been census, and 80% is moved towards preoperative.
Yeah, so we've also made that switch. Wherever feasible, we go in for brachytherapy in no small measure, thanks to also Dr. Lashkar, who had come to the institute once. We've made that switch, wherever feasible, brachytherapy, and if not feasible for various reasons, go to preoperative radiation. So, Dr. Kadresan sir, now this patient has come to you after preoperative radiation. It's very close to the bone, abutting onto the bone, and now we know that if the bone gets significant amount of radiation, there's a risk of path fracture, which is difficult to heal and treat. So, would you like to, after surgery, when you go ahead for surgery and resection of the tumor, two questions here. What is your surgical plan, and what are your indications for prophylactic fixation of the bone itself? Dr. Kadresan?
Yeah, I unmute.
Yes.
Yeah. See, usually what I would have planned for a surgery followed by postoperative radiation in this setting. If we have given either way, see, it depends on during the resection, how far it is from the bone is what is a thing we have to look at. If the tumor is moving over the bone, then I'll be taking the periosteum as the margin on the femur. But again, as you see in other image, what you have shown that it is very close, or it is very close to the patella. Probably a portion of the patella where we need to resect in this tumor, and along with the margins of muscles all around.
Right.
And regarding the prophylactic bone fixation, if I bone, then I'll look at doing a prophylactic bone fixation. If our resection is going to be only the periosteum, I think prophylactic bone fixation may not be required in this setting.
Perfect answer. So the postoperative histopathology was synovial sarcoma. Now, coming to Samir. Samir, would you like to use the sarcoma, the Sarculator app, or would you like to give the periosteum is resected, patients receive new joint therapy, deep-seated high-grade tumor, abutting onto the bone with periosteum as resection? What would be your plan for adjuvant therapy? Adjuvant chemotherapy.
I was just asking, what is the size of the tumor?
Size of the tumor is about 5 centimeters.
It's 5 centimeter. Perhaps it will not fit for, I mean, considering grade 3, size 5 centimeter, and the age was, I'm sorry, I forgot the age.
31 years.
31 years. So the risk of recurrence in this case comes to be the overall survival 10 year is 72%, and 5-year risk of distant metastasis is 28%. Again, it is quite a number. 5-year distant metastasis, 28% is something which cannot be neglected. But we usually, the data like we usually give, and it is 50%. So we will talk to the patient. We will explain about this key. It is a chemosensitive tumor. Risk of distant metastasis is 28%. As such, data is not there. But again, probably I will err towards giving it, though data is not there. In case patient says, and this is patient-to-patient discussion.
Right. So that is what we did as well. And this patient subsequently received adjuvant chemotherapy. Again, we'll quickly go through these a couple of other cases. A 13-year-old girl was evaluated for mass and pain in the right thigh of 4 months duration. The size was 15 into 12 centimeter mass in the anterior aspect of the right proximal thigh. No significant inguinal nodes. And this is what was the MRI. So Gaurav, as we can see here, there are two things here. The tumor is filling up the entire space in the quadriceps muscle. It's abutting onto the bone for a bit, and it's also abutting onto the vessels for quite a distance. So would this be enough, or would you ask for something else?
The femoral vessels are almost like there is 180-degree at least abutment with those femoral vessels. So if it is a long segment abutment, then I would be prepared at a time when I'm doing surgery to have a vascular surgeon standby. If I can get away with the adventitia, then it is good. Otherwise, we will need to have a vascular surgeon on standby.
Would you ask for
the surgical aspect?
Would you ask for an MR angiogram or a CT angiogram at the time of doing the MRI, or later on as well?
Yes, CT angiogram will definitely help, sir, in a supplementary investigation.
Right. So we did a CT angiogram. So the report was that it was encasing the common femoral artery, the superficial femoral artery, the profunda femoris artery, and the lateral circumflex vessels. And the deep veins of the thigh, the great saphenous vein, and the common femoral vein were not visualized. So what clinical significance, I mean, what does this angiogram report tell you? Dr. Jyoti, you can take this question.
Definitely all the arteries are encased, but the vein is not visualized. Means either the vein is compressed or it is involved, but I cannot see any collaterals in the imaging. So I think most of it, I think it is either there is a thrombus in the vein or it is compressed. That is why it is not visualized. But the artery then encased. So I believe the vein is also involved by the tumor.
So any significance of the great saphenous vein not involved or something? I mean, would you give
we can use for recon. That can be one thing, that reconstruction part, or we can leave, because in this, when both artery and vein are involved, and we have to do only one reconstruction. So if the vein is patent, in that case, we can leave the venous reconstruction. We can go ahead only with the arterial reconstruction.
Yeah, excellent point. So if the great saphenous vein and the venous return, the great saphenous vein is there, you might not need to reconstruct the femoral veins. only reconstruction of the artery itself may be sufficient, and you may not have to do venous reconstruction. Again, the biopsy was a synovial sarcoma. The FNAC was negative for metastasis. CT chest was negative. Dr. Lashkar, again, here the patient comes to you, again discussed in MDT for overall treatment. So, Dr. Lashkar and Dr. Samir, we now know that this patient would definitely need adjuvant radiation. And we also know that this patient, the vascular encasement is there. So there's probably some chance of vascular invasion. And we know that if vascular invasion is there, there's a chance of metastasis is slightly higher. So although it is amenable for upfront surgery, would you like to consider a systemic therapy in view of vascular invasion / risk of metastasis? And we have, after we resect, we may have to reconstruct the arteries, veins, and so on and so forth. So does that, Dr. Lashkar, does that make you think about giving giving radiation before or after surgery? Your thoughts, Dr. Lashkar and Dr. Jifmi and Samir.
Yeah, Jifmi, you want to take that?
Yeah, so given the situation that the tumor is encasing the vessels as well as the neurovascular structures, so preoperative RT should be a better choice than postoperative RT. I would agree to that. And I think Dr. Samir can take up the question on systemic therapy.
Yeah, so if, we have given here neoadjuvant chemoradiotherapy. So in case surgeon says, and we give, when surgeon says that probably it is unresectable or maybe it is borderline resectable, then I believe that chemoradiotherapy might not be that toxic that was considered once to be.
No, Dr. Samir, I'm talking about it's operable. There is no doubt about the operability. The lesion is well operable. The only thing I'm stressing on here is that the vessels are encased and the vessels are probably invaded. Once the vessel is invaded, there is a chance of having microscopic disease, distally in a distant metastasis is much higher. That
doesn't affect chemotherapy. You give neoadjuvant radiotherapy or this. This is a theoretical possibility, but yes, as such, this is not taken into consideration while planning chemotherapy. I understand your point, but this is not Ewing sarcoma or this round cell tumor in which suddenly micrometastasis might be considered. I'll just add a point. There are lots of students that any sarcoma, when synovial sarcoma is there, they must get translocation done, because lots of times we come to know that it was treated like synovial sarcoma, and down the line, after 2 or 3 lines after everything, it was something else. So molecular marker must be done every time.
Excellent point, Dr. Samir.
Yeah, I just, Anand, can I just reiterate on the point that Samir made? That's a very, very important point that is made. When we are taking a call on whether you want to give preoperative radiotherapy or chemotherapy in a patient where the vessel is actually encased by the tumor, it is more to do with making it resectable from a borderline resectable rather than trying to reduce the risk of distant metastasis, because that really doesn't happen because of infiltration of the vessels. Unlike in a round cell sarcoma, where it's a completely different thing. And that, again, Samir very nicely alluded to. It is extremely important to identify whether it's a round cell or a non-round cell. And that's where the translocation studies come in.
I think excellent points by all the panelists here. So we've already discussed the role of neoadjuvant therapies. Surgical plan would be to resect and remove the vessels. Dr. Jyoti, any choice of preferred grafts? Would you biological, non-biological? What would you do here?
Yes, autologous graft is, I think, always preferred, and because there's chances of thrombosis. So if the contralateral saphenous vein can be used, but if we need to see the caliber of the vessel and then take a call. And sometimes we have used both the saphenous vein as well as the PTFE graft. So autologous graft is always better, I believe. I just want to make one more point that when we have few cases where we have seen pre-operative radiotherapy and done vascular reconstruction subsequently, and the problem is with the wound healing and with the graft take-up. So in majority of the cases, we had problem with the graft patency and the wound healing, especially where we have given preoperative RT when vessel was encased. So I would go for more of adjuvant RT and in such cases.
And
Yeah, I just want, can I add?
Yes,
I
sir,
think
yes, sir.
I agree with Dr. Jyoti, because when we look at, see, the extent of surgery is not going to change either it is pre-operative or post-operative radiation. So when we give radiation pre-operatively, then they'll be covering at least 5 centimeters above and below, where our extent of our resection, vascular resection will be up till that level. So I will also be very, very skeptical about doing a vascular reconstruction within the field of RT, where the RT is given. So rather, I'll try to do the surgery first, followed by adjuvant radiation.
Jimmy, you want to comment on the margin?
Just a point regarding the contouring. So this is what the emphasis was, that currently the margins that we take to the gross tumor and the clinical target volume that we expect for the microscopic disease extent is not around 5 centimeters. So it will be around 2 to 3 centimeters in the axial direction and in the longitudinal axis, and circumferentially we take around 1 to 1.5 centimeters. So a lot of the toxicities that happen due to radiotherapy is applicable to the technique that you use, the way you contour and how you plan. So if there is no regard taken to the skin covering the tumor, as well as if we take give extensive margins to the disease, so it is definitely going to lead to postoperative complications. So the extents have with the current trials from Vortex, the margins that we need to give have currently come down to 3 centimeters longitudinally and circumferentially around 1 to 1.5 centimeters. So maybe those points will give a balance of the toxicities post radiotherapy.
So, Dr. Gaurav, is reconstruction of the vein always necessary? What are your thoughts on that?
Sir, here the deep veins are involved. So, if we the saphenous vein is intact, then it's good enough. If we harvest the saphenous vein from the opposite side to reconstruct the deeper veins if they are involved, probably not always necessary if there are good collaterals.
Right. So just alluding to what was mentioned with the previous speakers, we try to look at what happens to the vessels when a soft tissue surrounds, when a sarcoma kind of, completely encases and surrounds a vessel. So we saw that in most instances, exactly like what Samir said and Dr. Lashkar very correctly said, that we should treat the primary without concern for what happens to the distant metastasis or not. Because in our own series, we saw that at 75% of the cases, the vessels were just encased without involvement of the vessels. Contiguous invasion was seen only in 4% of the cases. And in about 20% of the cases, there was the adventitia was intact, but there was discontinuous tumor emboli within the vascular lumen. Again, the patency rates, like Dr. Jyoti said, were much better for the autologous graft and then for the synthetic grafts. Okay, so coming to the next.
We got.
I think we are out of time. I think
you wanted me to warn you, so I'm.
Yes. I think let's all stick to time. I think sticking to time is the correct thing to do, and I will end my case here. And I will.
Anand, maybe just as a grace time, instead of doing another case, if somebody has any other questions, burning questions that one may want to answer,
sir, I have a question, sir. I have a question. Sir, this is not related to this, but in Ewing sarcoma, sir, we are doing volumetry nowadays. And if volumetry, you have like surgeries and prosthesis is there, do you do radiation post prosthesis? I mean, if the indication is more than 200 ml, or the original volume has not been encompassed and prosthesis is put. So a lot of time necrosis, the fear of necrosis is there, prosthesis necrosis. So my question
you don't have any burning questions, sir.
That's Ewing's, Samir. You are only allowed soft tissue, non-round cell soft tissue sarcomas.
So I will.
Although I can answer you as a different on the phone.
So yes. I will be a little more selfish here and say, reserve all these questions, Samir, and don't leak the questions. You can ask all of them at IMSOS. So Dr. Deep Jyoti Kalita has a question. Is there a role for a PET CT scan in evaluating for skip metastasis or distant metastasis? Dr.
No,
Gaurav,
sir.
Yeah. So as of today, Yeah, please go ahead. Please go ahead.
So I think I can complete your sentence. As of today, probably there is not an established role of doing a PET scan.
Yes.
Right. Any other questions? Can somebody can put it up in the chat box? Or
I have a question, Anand, with your permission.
Please, sir. Please, sir.
This question was regarding the role of doing an ultrasound for any patient with the extremity soft tissue sarcoma. Is there an indication? I mean, there is an indication. That's why I'm asking a question. So basically, just to sensitize the juniors that there are there is a histological subtype where one would recommend doing an ultrasound of the abdomen in the patient with the extremity soft tissue sarcoma. So, I mean, I'll answer the question. What I wanted to bring up was that in a histology of a myxoid liposarcoma, the incidence of abdominal metastasis is in the range of about 12 to 15%, not in the rest. So if you have a patient with a myxoid liposarcoma of the thigh, then the recommended investigation also includes ultrasound of the abdomen and pelvis. I mean, I just wanted to add that.
Dr. Sriraj Rajan had a question. Will an ISP, could you please clarify what do you mean by ISP? I'm not sure. I'm very bad at short forms and terminologies. In situ preparation. Sorry, we wrote a paper on it. Will an in situ preparation help in neurovascular encasement? Again, there's a wonderful paper that, there's a paper that we wrote, and there's a wonderful paper that's also been submitted to IMSOS that will come up probably in the oral presentations. You can come and listen to it. But yes, in situ preparation is a very good technique. What we basically do is what Dr. Kadresan sir had said, that if the tumor is encasing the vessels, we also know that from the paper by Dr. Kawaguchi, the epineurium of the tumor is a margin. So in low-grade tumors, what you can do is you can separate the tumor out from the nerve. So the nerve is there, then the tumor is there, and then the nerve is there. You can separate the tumor, make sure that there's no spill, separate the operative bed from everything. You can bivalve the tumor. You can take the tumor out, remove the epineurium, dissect it out, and then you have to send multiple frozen sections from there. And then you can use either absolute alcohol or hot water, saline, and prepare the nerve. And if the frozen section from the epineurium is negative, then you can consider that nerve to be saved. So it's a very good technique to help in neurovascular encasement. But then again, it is used mostly only for low-grade tumors, not used that much for high-grade tumors, because in high-grade tumors, you don't know at which place the frozen section might be positive. I mean, the place where you give the frozen section might be negative, but adjacent to that, it might be infiltrating the vessels. So it's an excellent technique for low-grade tumors. Agreed.
Great. There's one last question
just to add to
Vinita. Pratik, you wanted to say something?
No, just to add to what Anand has told, when you are looking at preserving the nerves or preserving the vascular structures when they are very close, very clear, when they are encased or so, your understanding about the preoperative MRI is very, very, very crucial in such cases. See, you need to know exactly where the tumor is. See, when you have a tumor which is encasing, but then that region, when the nerve is slightly enlarged, or as Anand has said, that when there is vascular involvement, if there is tumor tissue within the usually the vein and the artery will be in one will be encased in one facial compartment. If there is compression of the vessel but not the artery, and if there is some tumor cells, some thickening, if you can see on MRI within the neurovascular bundle, then that means the neurovascular bundle there is tumor within it. So in such a case, you should not be looking at preserving the nerve or the vessel or so. So there it will not be, ideal. So where, as Anand said, it is ideal only when there is encasement, but the nerve inside is, pitch normal on imaging. And in that setting, maybe we can look at doing in situ preparation or whichever other techniques we can look at in a low-grade tumor, but not so in a high-grade tumor.
Dr. Vinita, you wanted to ask something? Quick question.
Yeah, I have a 80-year-old gentleman who had a pleomorphic high-grade sarcoma in the leg in front of the tibia, up just below the knee joint. and it was infiltrating the skin also. It has been excised, but he also had inguinal lymph nodes, which have also been dissected, and 3 out of 21 nodes are positive. So, and he's 80 years old and not fit for chemotherapy. Should we give radiation therapy, or should we consider that this is a metastatic disease and not give radiation?
Question to me, Vinita.
Yes, sir. Yes, sir.
So locally, it was a big tumor?
Big tumor with skin infiltration.
Okay, so that means in terms of indications for radiotherapy locally, if I remove age out, radiotherapy was indicated. Radiotherapy for the inguinal region, you have done a dissection, 3 nodes are positive. The evidence is available that if you have a large node with perinodal extension, if you add post-op RT, local control at the inguinal region improves. But in this patient, if there is no perinodal extension, keeping in mind old age, 80-year-old, we would not radiate the inguinal, but if possible, we would have considered radiotherapy for the primary site, which would not be toxic.
Okay, thank you, sir.
Pratik, there was something that you said. You are the main coordinator, so I can't deny you.
I just said that I think we need to end this discussion because this can go on.
Yes.
And considering that it is meant for students, and I think this is already beyond the scope of some of them.
Yes.
So with your permission, I think we would like to just go on to the quiz part of it.
Yes.
Sure. Thank you very much. Thank you.
On a light note, your screen is looking quite scary, Pratik.
Oh, is it? I'll just stop there.
Mirroring Dr. Laskar, Dr. Anand, and me as well.
So I think my camera doesn't like me. So I'll just stop my video. And yes, so thank you all for that fantastic discussion on this management of soft tissue sarcoma. Hope there was a lot of thinking points for all the people involved. Now, what we are moving on is the Kahoot quiz. This is the quiz that we have at the end of all the sessions. For this, you need to download the Kahoot app, and then we will start the game. So I'll share my screen, and then we'll just go on discussing. So in this, can you see my screen now?
Yes, we can see.
Yes. So now before we start, so there will be a demo quiz so that the participants can understand how to play this. And then we'll start with the main quiz. So for playing this, you will need to download this Kahoot app on your phone so that you can play the quiz. We'll be starting with the demo quiz first, and then we'll move on to the main quiz. So this quiz is actually meant for the PG students and young consultants. The panelists can join, but may not get the prize money. So I'm just requesting everyone to just download the Kahoot app and log in for this quiz. We'll be sharing a game pin on this, and you have to enter that game pin on the app, and then we can start. So I'm just waiting for the quiz to load. Remember, this is the demo quiz first, just to show how it is played. And the main quiz will be after this. So the demo quiz pin is 3703022. So if you have downloaded the app, and you can just open it, and there you will have a section where you have to enter this. Since there are around 66 participants right now, I'm hoping at least half of them join in. So we'll wait for 30 people to join in. And remember, this is just the demo quiz first. So the purpose of the quiz is very simple. You answer it correctly and answer quickly. And the app calculates like who has answered it the fastest and the quickest, and then you're assigned points. So in the main quiz, we'll have 10 questions. And at the end of the 10 questions, the participant with the maximum points obviously wins. We have prize money for the first, second, and the third position. So it would be great if more people can join in. Be careful when you're entering the name. It would be helpful if you enter something that we can recognize so that we can assign prize money after that. Okay,
and like,
so this is
like Pratik said, it's very, very important, A, to be correct in your answers, and B, because Kahoot also takes the timing, the the person who answers
Yes.
first. So speed is as important as is accuracy.
Accuracy.
So
Yes.
be on your toes and think quick and act faster.
Yes.
So we'll probably just wait for a minute for everyone to join and then we'll start the quiz.
Yeah, that makes sense.
So by the time that people are getting added up, again,
Yeah.
we have a wonderful quiz at IMSOS 2023. It's a team of 2. Again, people can join in from within the same institution, different departments. It's a two-person quiz. You can even partner up with your friends or colleagues from other institutions. The prelims is again going to be a Kahoot based quiz at the venue itself, which is going to be in one of the prelims will be in one of the side halls on day 3. And the main quiz is going to be on, it's a 45-minute main quiz, and we have some absolutely rock star quiz masters, 4 of them in fact, who are designing a very exciting quiz. And this is not a regular quiz. You'll find that it's going to be a quiz with a twist, and I hope, and it'll be a twist for everyone, even for the faculty, for the students, for the attendees, for everyone. So hope that it'll be something that interests all of you.
So I think we have around 20 people who have joined in. So for the demo quiz, we'll start, and hopefully more will join for the main quiz.
Yes.
So people, this is a demo quiz just to give you a hang of how it works. So starting with the first question of this demo quiz. Who is the Prime Minister of India? Is it red, Amit Shah? Is it blue, Draupadi Murmu? Is it yellow, Narendra Modi? Or is it green, Rajnath Singh? So you can see red, Amit Shah, blue, Draupadi Murmu, yellow, Narendra Modi, or green, Rajnath Singh. So you have 10 seconds to answer that question. Prime Minister of India. Last 5 seconds. 3, 2, 1. Okay, so the correct answer is yellow, Narendra Modi, and that is how the points will be assigned. That person who has answered it correctly and the quickest. So now moving on to the second demo quiz question. Which of the following is the national capital of India? Is it red, Mumbai? Is it blue, Kolkata? Is it yellow, New Delhi? Or is it green, Bengaluru? So red, Mumbai, blue, Kolkata, yellow, New Delhi, or green, Bengaluru. So capital of India. So demo quiz number 2. So last 7 seconds to answer that. So the faster you answer, the more points you get. So 20 people have answered it correctly. That's how we play this game. So on the basis of that, then we have the winners selected based on how fast you are and how accurate you are. So now I'll just try and get the main quiz going. Just give me a moment. I'll just stop my sharing. So hopefully people got a hang of it, and now we'll be starting with the main quiz. And the same steps apply. You have to download, once you've downloaded the Kahoot app, you have to open it, and you'll be assigned a game pin, which you have to enter. So that game pin for the main quiz of today, soft tissue sarcoma, is being generated. So we want maximum people to participate and have an interactive session in this. So the main quiz game pin is 223871. So just enter this game pin in the Kahoot app and join in. And now this is the main quiz of today's session. Anand sir, is the game pin visible?
Yeah, it's visual and we can all see it. 223871.
Yeah, 223871. So I can see around 60 participants still in the Zoom meeting. So maybe we'll wait for at least half of them to join in. We'll give them a 2 to 3 minutes to join in. We have anyways exceeded the time limit in this section. So I think we can just relax and enjoy this concluding part.
I think 21 was the number.
And we've got to 21. I think we can start the 22. I think we can start the quiz.
Yeah, okay. So I'll just wait for half a second. Okay, 22 is the number. And now we'll start with the main quiz. Okay, so rules are simple. Answer correctly and answer quickly. Okay, starting with the first question of this quiz. The most common soft tissue sarcoma is it red liposarcoma? Is it blue rhabdomyosarcoma? Is it yellow synovial sarcoma? Or is it green undifferentiated pleomorphic sarcoma? So most common soft tissue sarcoma: red liposarcoma, blue rhabdomyosarcoma, yellow synovial sarcoma, or green undifferentiated pleomorphic sarcoma. The last 3 seconds to answer that. Okay, so majority have answered it as red liposarcoma, and then there is synovial and undifferentiated pleomorphic sarcoma, but the answer is rhabdomyosarcoma. So Anand sir, if you can just explain that.
So a lot of people don't, when they say which is the commonest soft tissue sarcoma, people usually think about extremity sarcomas most of the time. But rhabdomyosarcomas overall are the commonest soft tissue tumors. As we all know, they are most commonly found in the pediatric age group. They are mostly found in children. So they are usually a very aggressive form of cancers, very sensitive to chemotherapy. And we know that, they are subdivided into embryonal, alveolar, pleomorphic, and then there's the spindle cell or sclerosing, which is a new subtype that's added. So overall, they are the commonest because you don't see them in the extremities that often, but they are the commonest soft tissue sarcomas.
Yeah, so that was a trick question to start with since we didn't discuss rhabdomyosarcoma today. But overall, as Dr. Anand mentioned, that they are the commonest soft tissue sarcomas seen.
And Dr. Vineet did not say commonest extremity soft tissue sarcoma. So that's an important thing. Yeah.
So we start with a 0. So it's like no worries. Everyone is 0. So you have a chance to buck up and get into the game. So the next question: melanoma of soft parts is another name for which of the following? Is it red angiosarcoma? Is it blue clear cell sarcoma? Is it yellow epithelioid sarcoma? Or is it green synovial sarcoma? Melanoma of soft parts is another name for which of the following tumors? Angiosarcoma, clear cell sarcoma, epithelioid sarcoma, or synovial sarcoma. The last 5 seconds to answer that. And the correct answer, as we know, is clear cell sarcoma. Again, there has been varied response to this question. So Anand sir, if you can clarify that.
Yeah, so it's called as melanoma. The clear cell sarcomas are called as melanoma of soft parts because they are actually spindle cells, but they have uniform eosinophilic cytoplasm, which is completely clear. So that's why it's called as a clear cell sarcoma, and it's also called as melanoma of soft part because it arises in the soft tissues, and it's called as melanoma of the soft parts because it has melanocytic differentiation. In that, it tests positive for on IHC, it tests positive for the melanoma markers, which is the melan A and the HMB45, but it is primarily a soft tissue tumor. Because it has melanocytic differentiation with some IHC like melanoma, it's called as melanoma of the soft parts.
Okay. Thank you for that explanation. So again, a tough one. No worries. At the end of 2 questions, we have JG who is leading. We'll again have a look at the scoreboard maybe at the end of 5 questions. So moving on to question number 3 of this quiz. Patients with von Recklinghausen disease are at higher risk of developing which of the following soft tissue sarcoma? There's an image also. Red, angiosarcoma. Blue, malignant peripheral nerve sheath tumor. Yellow, fibrosarcoma. Or green, synovial sarcoma. Von Recklinghausen disease, higher risk of developing which of the following STSs? Angiosarcoma, MPNST, fibrosarcoma, or synovial sarcoma? Your last 5 seconds to answer that. And the answer is MPNST, and quite a lot of people have answered that. Anand sir, if you can just explain it. Dr. Anand, are you there?
Oh, sorry, I was muted. We know that the von Recklinghausen's disease is neurofibromatosis type 1. We know that NF1 leads to multiple neurofibromas. And we also know one very important thing, that all soft tissue sarcomas, unlike carcinomas, where there is a adenoma carcinoma, there is a benign tumor, which is adenoma, which then transforms into malignancy. And then, it metastasizes. In soft tissue sarcoma, it doesn't happen. All soft tissue sarcomas arise de novo. There is no benign to malignant transformation in that. All sarcomas arise de novo, except the neurofibrosarcomas, which is the MPNSTs, which can have a transformation from their benign counterparts, which is the neurofibroma. So neurofibroma to MPNST transformation is one of the only benign to malignant transformations that is known in sarcomas.
So von Recklinghausen disease, also called as neurofibromatosis type 1. So moving on to the next question. We're going to skip the scoreboard, and the following MRI image of a case of myxofibrosarcoma is showing what sign? Is it red crescent sign? Is it blue horn sign? Is it yellow smile sign? Or is it green tail sign? There's an MRI image where you can see the soft tissue sarcoma. It has myxofibrosarcoma. What is the sign that it is showing in the MRI image? Is it red crescent sign? Is it blue horn sign? Is it yellow smile sign? Or is it green tail sign? Again, a varied distribution of answers, but the correct answer is green tail sign.
So we know that in myxofibrosarcomas, they have the tail sign. Now, this tail sign is very important for 2 or 3 important reasons. One, it helps you differentiate tumor from what is edema. Second, if you know the tail sign, you will have to go and give margin not to the primary tumor, but you'll have to go and give margins to the tail. Otherwise, if you give margins only to the tumor, you'll end up with a positive surgical margin. And another thing is, because this tail extends for quite a bit on both sides, most of these tumors may not be amenable, or intraoperative brachytherapy might not be a very good choice for these patients. Maybe EBRT, either pre-op or post-op, might be a better choice for myxofibrosarcomas. Yeah, so that's something that we need to keep in mind.
Yes, it is more to keep in mind for the margins when you're planning your resection. So moving on to the next question. This will be the 5th question of the quiz. The following are types of liposarcoma except dedifferentiated liposarcoma, well-differentiated liposarcoma, mesenchymal liposarcoma, or myxoid liposarcoma. One of these is not a type of liposarcoma. Is it red dedifferentiated? Is it blue well-differentiated? Is it yellow mesenchymal? Or is it green myxoid liposarcoma? You have last 5 seconds to answer that. Following are types of liposarcoma except. And the correct answer is mesenchymal liposarcoma.
Yes, we don't have a mesenchymal.
If you can just highlight that.
We don't have a mesenchymal liposarcoma. We have many mesenchymal malignancies. We have a mesenchymal chondrosarcoma and so on and so forth. Yeah, I'm there. Can you hear me?
Yes.
Yeah, sorry. We have multiple mesenchymal tumors. We have mesenchymal chondrosarcomas and so on and so forth, but we don't have a mesenchymal liposarcoma. We have well-differentiated liposarcomas, D-diff liposarcomas, for which chemotherapy plays a very big role. But there is no mesenchymal liposarcomas. You have other mesenchymal sarcomas, which can, like for example, chondrosarcomas. Right.
Yes. So mesenchymal is not the answer. So at the end of 5 questions, we have Suraga who is leading, followed by JG and C. Hopefully, these are postgraduate students and not panelists hiding behind fancy names. So moving on to the next question, the 6th question of this quiz. The fusion protein most commonly associated with synovial sarcoma is red, EWS-ATF1, blue, PAX7 FOXO1, yellow, SYT-SSX, or green, WT1. The fusion protein most commonly associated with synovial sarcoma is red, EWS-ATF1, blue, PAX7 FOXO1, yellow, SYT-SSX, or green, WT1. And the correct answer is SYT-SSX. Dr. Anand.
Yeah, again,
what is
like
the significance?
it was already told here in this, earlier said, both by Dr. Samir as well as by Dr. Laskar, that the SYT-SSX is the predominant mutation that is associated with synovial sarcomas. In most instances, just a diagnosis of synovial sarcoma is really not enough. You have to actually go and prove that it is, mostly it is done by RT-PCR techniques. You have to go and prove that you have the SYT-SSX translocation, which is the commonest translocation that can occur after a synovial sarcoma. There can be certain other translocations as well, but this is the commonest one. And you need to, there is the SS18 SSX also that can happen, but you need to go and prove what translocation is there in a synovial sarcoma before you can arrive at the diagnosis.
Yes. And for people who have answered the other ones, so the EWS is, as we know, for Ewing's, and PAX7 FOXO1 is for Aptog, and WT1 is for Wilms tumor, and not with any soft tissue sarcoma. Anyways, moving on to the next question. There is some changes in the scoreboard. We'll have a look at it at the end of 8th question. So now coming to the 7th question, which of the following liposarcoma needs an MRI spine as part of its staging? Is it red, dedifferentiated liposarcoma? Is it blue, myxoid liposarcoma? Is it yellow, pleomorphic liposarcoma? Or is it green, well-differentiated liposarcoma? Which of the following liposarcomas need an MRI spine as part of their staging? Dedifferentiated, myxoid, pleomorphic, or well-differentiated? Dr. Siddharth did allude to it towards the end. So if
Yes.
people were listening.
Very correct.
And the answer is myxoid liposarcoma.
Right. So the MRI spine is usually needed to be done for the myxoid or the round cell sarcoma. There are few sarcomas which you need additional metastatic workup. The MRI spine for the myxoid or round cell liposarcomas, you need a contrast CT of the abdomen and pelvis for the myxoid or round cell liposarcomas, also for epithelioid sarcomas, angiosarcomas, and the leiomyosarcomas. You need to do an MRI brain for the angiosarcomas and the alveolar soft part sarcomas. And for lower extremity, if it's a well-differentiated liposarcoma, you also need to do an contrast CT scan of the pelvis. What Dr. Laskar was trying to say, for an ultrasound or a CT scan of the pelvis for a well-differentiated liposarcoma of the thigh. Okay.
Yes, thank you for that. So now moving on to the 8th question. As per the concept of curative margins by Kawaguchi et al., all are thick barriers except red growth plate, blue periosteum of an adult bone, yellow iliotibial band, or green joint capsule. So which of the following is not considered to be a thick barrier? Is it red growth plate? Is it blue periosteum of an adult bone? Is it yellow iliotibial band? Or is it green joint capsule? Last 3 seconds to answer that. Again, mixed response, but the correct answer is periosteum of an adult bone.
So we know that Kawaguchi gave this concept of qualitative margin, and they said that the thick barrier is a physically strong membranous tissue which has white tendinous luster, which can be either the iliotibial tract, the presacral fascia, or the joint capsule. And the periosteum of a young child or an infant is a thick barrier. A thin barrier can be a weak membranous fascia like the muscle fascia or periosteum of an adult, the epineurium or the vessel sheath. The growth plate also can be divided into two. If it's an infant or young child and it is thick, it is called as a thick barrier. If it has more linear appearance and an older child or an adult, it is a thin barrier. Now we know that, I'm not going into the details. Please read up the paper by Kawaguchi et al. On concept of qualitative margins. It's available for free download. The thick barrier is 3 centimeters, thin barrier is 2 centimeters, and joint cartilage is 5 centimeters. Okay, thank you.
Yes, so that's a very landmark paper, and everyone interested should go through it.
And it's available for free download. I mean, you can read it free.
Yes. So Suraga is still leading, and JG and C are second and third. You still have 2 more questions.
And Loveleen is climbing high.
Yes, Loveleen has climbed some 8 places. So coming to the 9th question, the following image is showing a process involved in what form of radiation therapy? You can see the image. What is it showing? Is it red, external beam radiotherapy? Is it blue, intensity modulated radiotherapy? Is it yellow, brachytherapy? Or is it green, proton beam radiotherapy? This was discussed by Dr. Nehal in her talk. Is it external beam radiotherapy? Is it intensity modulated radiotherapy? Is it brachytherapy, or is it proton beam radiotherapy? Last 2 seconds to answer that. And many have got it correct. So I think they were listening to Dr. Nehal. So Dr. Anand, if you can just...
we've already spoken about this. So the advantage of brachytherapy is that you put the wires and, you can start radiation on day 4 or day 5. It goes on for 5 days. So before the suture removal is over, your main surgery is also over and your adjuvant radiation is also over. So everything gets done in the same sitting. So it's a huge advantage in terms of time, cost, and stay. And we know that brachytherapy alone is equivalent to giving biologically effective dose (BED) of brachytherapy, and oncological outcomes are equivalent to EBRT, which is the external beam radiation.
Thank you. And now we will go to the last question of this quiz. And people have a chance to just overtake and climb higher. You have to be fast. The standard 2-drug chemotherapy regime used in soft tissue sarcomas. Is it red, high dose methotrexate plus ifosfamide? Is it blue, high dose methotrexate plus cisplatin? Is it yellow, ifosfamide plus cisplatin? Or green, doxorubicin plus ifosfamide? One of these is the standard 2-drug chemotherapy regime used in soft tissue sarcomas. Is it high dose methotrexate plus ifosfamide? And everyone has answered. And maximum answers is doxorubicin plus ifosfamide, which is the correct answer.
So we know that there have been 2 trials. Basically, there has been the SMAC trial, and then there's been the updated SMAC trial, both from Canada. And we know that the benefit in terms of survival that came in because of the addition of ifosfamide. And we know that ifosfamide can cause problems with fertility. So whenever you give chemotherapy for patients with soft tissue sarcomas, please talk to patients about fertility issues and the like. And we also know that as a single drug, the drug that is most effective as a single agent in soft tissue sarcomas is doxorubicin. So the answer is doxorubicin plus ifosfamide.
Thank you for that explanation. So now we come to the end of the quiz, and we have the final podium presentation depending on the position. So on number 3, we have C. Unfortunately, we don't know who that C is. On number 2 is JG. And in number 1, we have Suraga.
Excellent.
And
well done, Simba and Nick, whoever it is.
So if Suraga is still logged in, can they just switch on their video and we can just hear from them as to how they had experience of this quiz and also of the main session per se.
Yes, sir. Good evening, sir.
Hi, Suraga.
Hi, sir. Sir, I'm a MCS surgical oncology resident. I'm
Okay.
doing Cuttack, Odisha.
Okay.
So it was a very good session, sir. I mean, it was very informative, covering most of the things. And thank you for the very nice session, sir.
Okay.
Congratulations, Suraga. Congratulations. Well
Thank you,
done.
sir.
Yes. We'll be getting in touch with you for the prize money. But
Okay.
Congratulations for participating and for winning this.
Thank you, sir.
So I think, sir, that's it. That's it
I think
this session.
I think a big thanks to quite a few people here. A big thanks to all the, the biggest thanks goes to all the people who've came in, all the delegates who've come in on a Saturday, on an evening and come and listen to the talk that all of us had to give. So, thanks all of you. Thank you so much for coming and listening. A big thanks to Pratik. He's really coordinated, everything. He was after me, after everyone else, to make sure that we get our, we get our act in time. So thank you, Pratik. Without you, this would not have happened. A big thanks again to Lashkar sir, who kind of coordinated the meeting, made sure that the speakers are in the right places. We have the right people for the right talks, and the program is nicely done. So thanks to Lashkar sir. Thanks to all the panelists, who without hesitation, the moment we call them, would to come and talk. All of them were, more than willing and very happy to talk. I did not have to ask them a second time. Thanks to all the speakers who came and gave their valuable time and effort here. Again, a very big thanks to Dr. Ashish Gulia, who is really, and from the Tata Memorial Hospital, again, everybody there, all faculty members there, and Dr. Ashish, who really spearheaded this Sarcoma Education Foundation, the basic idea of which is education. It is to teach the postgraduates the basics of oncology, the basics of extremity oncology. A big shout out to them, that without them, it is their vision, and without all of that, none of this would have happened. Thanks to everyone. Thank you everybody for being a part of this. Thanks.
Thank you very much, Anand. Thanks to you also. You put in a lot of efforts too, and all the best for IMSOS. And again, like Anand said, please do participate. We want the maximum participants in IMSOS in Chennai. See you very soon.
Yes.
So have a good weekend. Thanks, Pratik, also for the
Thank
hard
you,
work
sir.
that you put in. Thanks. Bye.
And the next meeting, as you can always see, as you can already see up there, is on limb salvage surgery on 11th of March. Again, we have two, like we say in Hindi, two pataka moderators. We have Dr. Manish Agarwal, who's extremely good, and Dr. Manish Pruthi, again, who's brilliant. So hopefully that will be a very exciting program to attend as well. So I invite everybody who is here today, not only to attend the program on 11th, but to tell all their friends and their colleagues to attend the session as well. Thank you so much. Thanks, Pratik. Thanks, everyone.
Thank you. Bye-bye.
Thank you very much.
Bye. Oh, Kadir sir is also here. Sorry.
Thank you. Thank you so much.
Bye, sir. Bye, sir. Bye, sir.
Thank you very much. Bye.
Bye.
And for the participants who took part in the quiz, the second and third, unfortunately, we don't know your names. So you can just email us the details. If you have taken a screenshot, that would be great. And you can just email me on my email ID, and we'll then transfer the prize money. Now, because of the short forms and the usage of one letters, we don't know who the winner of the second and the third prize is. So do get in touch with us for that. Thank you. And hopefully you all will join us for the next session on the second Saturday of March, 11th March, 5:30 to 7 p.m. It's on limb salvage surgeries. Thank you, Mr. Hemant, and Somnath, if you're still there.
Yes, sir. Thanks, sir.
Yeah. Thank you. And thank you to Amit also for conducting this meet. So see you guys in March, and we'll be in touch regarding the program.
Sure, sir.
Thank you. Thanks a lot.